people would prefer to give things or to give services than to give cash. We have a mentality as human beings that people living in poverty are subhuman, and I'm saying that very strongly.
Welcome to Global Dispatches, a podcast for the foreign policy and global development communities and anyone who wants a deeper understanding of what is driving events in the world today. I'm your host, Mark Leon Goldberg. I am a veteran international affairs journalist and the editor of UN Dispatch. Enjoy the show. A new study out of Kenya shows that one of the most impactful ways to reduce infant and child mortality is to give cash, no strings attached, to pregnant women. A randomized control trial by economists from UC Berkeley and Oxford University found that unconditional cash transfers reduced infant mortality by 48% and under 5-year-old child mortality by 45% in rural Kenya. These results would make this particular intervention as impactful for improving child health as the provision of vaccines or antimalarial drugs. I'm joined today by Dr. Miriam Laker-Oketta, Senior Research Advisor at GiveDirectly, which is the nonprofit that conducted the cash transfers upon which this research is based. In our conversation, Dr. Miriam Laker-Oketta talks me through why it is that well-timed cash transfers to women at the end of their pregnancies so dramatically improves health outcomes. She also explains how this new study adds to mounting evidence of the impact of unconditional cash transfers to people living in poverty in the developing world, and why it is at once logistically easy but politically difficult to scale up interventions like this. As regular listeners know, I love doing solutions-focused content here on Global Dispatches, particularly when it comes to solving some of our greatest global challenges, and this episode squarely fits into the kind of solutions journalism that I absolutely love to do. And as always, if you want to pitch me a solution, you can do so using the contact button on globaldispatches.org. And while you're there, you can also sign up for our newsletter and get a paid subscription to support my work. Thank you. Now, here is my conversation with Dr. Miriam Laker-Oketta, Senior Research Advisor at GiveDirectly. Miriam, thank you so much for joining me today. Let's just jump right into it. What did your study find?
So our study was conducted in rural Kenya, a program where households were given $1,000 each, which is approximately 75% of the annual consumption of a home in rural Kenya. The findings of this study are extremely amazing on the infant and child mortality side. We found a 48% reduction in infant mortality and a 45% reduction in the deaths of children under the age of 5.
Those are staggeringly huge numbers on par with routine childhood vaccinations. So in your study, you gave this massive windfall to pregnant women. Could you just describe that process a little bit more about when you gave this money, who you gave this money to, and what those women who received the money did with it?
So this program was not designed for the infant and childhood mortality reductions that we have seen. It wasn't a health program. It was one of GiveDirectly's normal poverty alleviation programs where we give large lump sum cash transfers, about $1,000 per household, in the hope that it will help them to meet their immediate needs and also to be enough for them to invest in other wealth generation investments that will hopefully help them get out of poverty. So about 10 years ago, GiveDirectly in rural Kenya gave cash transfers exactly like that to multiple households in multiple villages. They did not target women. They did not target pregnant women. They did not target children. This happened around 2014 to 17. About 10 years later, a program called Give Well, an organization that is a charity navigator very interested in the mortality effects of development interventions, funded a group of researchers who were already doing another research within the setting of the same program to have a look at that community and see whether there was any effect on infant and child mortality. What we saw and what the researchers saw that happened was that in households that received the cash transfers when a woman was around the time of delivery or had just had a baby, these women were more likely to have their babies in a hospital. So there was an over 50% increment in hospital deliveries. But also, in addition to that, these women reported that before the babies were born, they were feeding much better than before. The households were less likely to run out of food. The women said around the time of delivery, they were more likely to rest. So in the third trimester, when normally doctors would ask women to rest, they were able to rest because, unlike before they got this windfall, they had to continue working because that was the only way their families would get to eat or have any money for their essential needs. So women reported being able to rest during that time of pregnancy, but also in the first 3 months after a baby was born, which, if you look at it, Mark, that is what maternity leave usually is. So, in a sense, women were able to have maternity leave. And so they had their babies in hospital. There was a lot of reduction of mortality from factors that are related to births, the complications during delivery, prematurity, and other neonatal complications. And then also, they reported that their children were feeding much better. So the household as a whole was even better fed than before the cash transfers arrived. So it was really obvious that the windfall of this cash transfer was the reason that these families were able to get the outcomes that we have seen.
Yeah, it would make like intuitive sense that someone who is, otherwise very poor suddenly has this windfall. They are pregnant and very close to birth or right after birth. And so they're able to, number one, give birth in a hospital, number two, eat better, number three, not have to work, potentially, very laborious work as well. And everyone benefits from that. And so that's why it seems the findings were so remarkable.
And speaking from my personal experience as a medical doctor as well, I worked for a long time in poor settings in Africa, rural and even among the urban poor. And when I saw the results of this study, it was just a strong flashback to my time working in a particular very well established hospital in northern Uganda. And one day I was on call. This young lady is brought to hospital after being in labor for 3 days. Her baby is already dead and actually hanging out of her body. And when I spoke to the family and asked them why it took them so long to come to the hospital, they said it was simply because they could not put together money in time to rush her when she got into labor. So people are not coming to health facilities, not because they don't know that they should come, but because it's just so economically difficult for their families to make these decisions for them. And so when we look at these cash transfers, that is what it helped these families do at a time that they needed it the most.
So, this latest study kind of fits into a growing number of studies about the impact and effectiveness of direct cash transfers on people who are otherwise very, very poor. Can you just kind of fit this particular study into that growing body of evidence that these kinds of unconditional cash transfers tend to be, a fairly impactful way to reduce the impacts of extreme poverty?
I look at it from three angles. The first one is that it tells us what we already know about cash transfers. Cash to date is the most studied development aid intervention with over 300 rigorous studies that have been done across the globe. And this study has results that fit exactly into what we already know. Cash improves access to food in terms of food quality and quantity. Cash improves asset acquisition. Cash reduces psychological stress. But what is new that this study is telling us about that we are also very excited about is cash works down the generations. In this case, it did save the lives of babies who had not even yet been born or had just been born into those households. It did not only improve livelihoods, but it also saved lives. The third thing that I see from this is a question that we get very often in many of the places we work, people say, why don't you pair cash with other things like training people how to use their money? And GiveDirectly doesn't do that. We give cash unconditionally. But what we normally say is cash might actually work better when you improve infrastructure. And the results of this study spoke exactly to that. What we saw in this study was that people who lived near health facilities or were able to access health facilities had much bigger outcomes than those who lived far away from the health facilities. So, what is also new in this study is that cash works to complement existing health services. And that way, you have a boost in the impact of the cash transfers, but also a boost in the impact of the existing health facilities.
So interesting. I mean, to me, that actually speaks to a certain extent to the limitations of cash transfers. As you said, all of these studies show the real profound impact of unconditional cash transfers, but it seems that these impacts are limited, if not paired with other interventions. In this case, like health infrastructure, actually having a hospital around.
That is true, but maybe it also tells us the limitations of investing only in infrastructure and not providing cash to the people who are the intended beneficiaries. In this case, the health facilities already existed, they were running, but people were not having their babies in the healthcare facilities. So it didn't matter that the facilities were there. But as soon as they got cash, they were able to access the facilities physically, which means travel there, but also afford the services that were given. So just to be very clear about what I'm meaning by the health facilities, in this study, they found that the better outcomes happened when the babies were born in a hospital, not any health facility. So in a hospital in sub-Saharan Africa, when a health facility is called a hospital, then you know that it is staffed with physicians. And of course, then it has more robust resources like a theater that works and maybe even blood when people need it. So what we see in this case is the limitation of both cash transfers and the infrastructure. What we need is for them to work together.
I pose that question to you because we are in the midst of and entering a deep funding crisis in global development. We've seen a massive scaling back over the last several months from some key traditional donors, including in the United States, which shut down USAID and ended most foreign aid. And of course, Europe as well is also scaling back its foreign development assistance. And so these dollars for the kind of interventions that GiveDirectly does, and also the kinds of support that has traditionally been given to, say, rural hospitals in Africa and in Kenya, is even more scarce. What does that suggest to you, therefore, about the role of cash transfers as we enter this era of global development funding scarcity?
I think if you looked at the results of this study just as they are, one of the things that looks like a setback or concern is that it cost about $286,000 per life saved. However, this is because the program, as I mentioned earlier, was not targeted for infant and child mortality, meaning everyone in the community got these cash transfers. But when the researchers did the math and said, what if this program was only targeted to women that were pregnant, that lived in an area that gives them access to a healthcare facility, how much would it cost per life saved? And that came down to about $68,000 per life saved, which is at par with the current infant and child mortality reduction mechanisms, for instance, malaria treatment nets, childhood vaccines, and even malaria chemoprophylaxis. So, in terms of the cost in the setting of a reducing global funding budget, using cash transfers is actually plausible because it's actually cheaper than we thought that it would be. But I think the other thing, a lot of the budgets that in development aid were helping infrastructure. And so even when the funding has reduced, we know right now it's estimated that over 3 million lives will be lost. But to be positive, a lot of this infrastructure already exists. There are doctors, there are hospitals that have been set up. These already exist, roads that have already been set up. So these are still going to exist. And so bringing in a new intervention like this one that we've seen has a massive impact on a key development indicator, which is child mortality, and layering it onto what is already existing, I think is one of the clever ways to do this as we wait for funding to hopefully come back up. But even if it doesn't, we know that there's a cheaper way to reduce infant mortality as we wait for things to stabilize going forward. So it is not a solution completely. We're not going to say cash transfers alone is efficient and therefore we can do it alone to reduce infant and child mortality. We still need infrastructure to be in place, take advantage of what exists right now. But as we talk about this, policymakers also should be alert to this, right? Can we make sure the existing infrastructure is maintained? Even if we're not starting new ones, can we make sure that people who are close enough to access it are given the means to access the facilities?
So this study shows the real effectiveness of cash transfers in this very particular situation. Are you able to or have plans to scale up these programs? I mean, you've done the study to prove that it works. So what comes next in terms of trying to reach even more pregnant women with this kind of intervention in Kenya and beyond?
Because we have the results now, we think it is time to get moving. One of the things that we are doing is we're talking about this at a large scale because we want people to know these results. It might be researchers who want to replicate this study. It might be donors who want to fund this work going forward, whether funding GiveDirectly or any other organization that is doing cash transfers. It might be policymakers who are talking about ways to reduce infant and child mortality in their countries. When you look at almost every country's development plan in Africa, infant and child mortality is one of those that is listed. So our objective now is to get this conversation going. However, within GiveDirectly as well, we've decided to take the next step. This study showed us one, that if you target better, meaning if you identify women that are already pregnant, give them a large cash transfer during pregnancy, and then partner with the health organization, you might actually be able to get the same level of outcomes or even higher. And so we are right now partnering with an organization in Kenya called the Luala Community Alliance. So this community alliance is a healthcare system that works with the community. They take advantage of what they call community health workers. These are really volunteer health workers who work within the communities and reach every household in their communities. So this system is already in place. Luala has been working for a while. It is in place. Community health workers reach out to pregnant women, encourage them to feed well, come to the healthcare facilities. So what GiveDirectly is now doing, aligned with the results from the study, is to simply give cash transfers to the women who are pregnant living in the catchment area of Luala. So we believe that that is a way that we are immediately translating the evidence what we have from this study into practice. So that is one thing that we've started. The cash transfers will start going out in September this year.
I mean, could you imagine a world in which the results of your study are taken real seriously by donors, and in one in which this is expanded sort of beyond a catchment area in Kenya to, say, all of rural Kenya or all of rural sub-Saharan Africa? What would that take, that kind of massive expansion?
A hard question to answer, but I think it is answerable. So, if we've been able to take childhood vaccines to the end, like the last mile home, if we've been able to take malaria nets to the last mile, because those interventions need a lot of manpower to deliver them, then why should it be difficult to do cash transfers that simply needs someone to have the most basic cell phone and have this cash sent to their phones? I'm bringing that up because the scalability of cash transfers is probably one of the fastest, if not the fastest, among all the development interventions. So I think we shouldn't be afraid of thinking about scaling because GiveDirectly has done cash for about 15 years and we did not invent cash transfers. It has been done all over the world. There is a good blueprint that can be used to scale this intervention. Also, it is quite cheap. It is very efficient. On average, this kind of program that found these results has about an 85% efficiency, meaning for every dollar that is donated to the cause, 85 cents reaches the recipient. So, from the perspective of scaling, I think it's very cost effective to scale, but also very easy to scale in terms of the activities that are involved in scaling a program like this.
Earlier in this conversation, you noted that there are more than 300 rigorous academic studies at this point demonstrating the impact and effectiveness of cash transfers. And just now, I really appreciated the similarity and comparison you brought to kind of delivering a malaria bed net to the last mile or a vaccine to the last mile, to the hardest reach people, the hardest to reach rural areas in sub-Saharan Africa. Yet, like, why at this point over the last 15 years has this massive scaling up of cash transfers not occurred yet, if you do have all of this evidence of its impact and it is scalable in a much more cost-effective way than, say, getting vaccines the last mile, why haven't cash transfers been scaled to that effect?
So I've worked in the cash space for about 5 years after having been in the health field for several years. What I'm seeing is that the way we treat cash is very different than the way we treat all other interventions. And I believe that this comes from a place of being paternalistic. I'll give an example of antiretroviral therapy. Antiretroviral therapy was very expensive, but when one randomized control trial was done and it was proven that antiretroviral therapy actually reduces the risk of death from HIV, it was immediately rolled out as a standard of care for HIV. And in 2002, it was rolled out freely in the entire low and middle income countries in the world. Cash, on the other hand, has a funny relationship. People would prefer to give things or to give services than to give cash. We have a mentality as human beings that people living in poverty are subhuman, and I'm saying that very strongly. We think people living in poverty are poor because they chose to be poor, and therefore, because they chose to be poor, they don't know how to use money. We forget that birth is really the first lottery. We don't choose where we are born. And most of the people in poverty were born in poverty, or people who are living in poverty most of the time had some issues in their lifetime that led to poverty. So it is not chosen. And what we have seen over and over in GiveDirectly is when you give people cash transfers, they know what to do with it. They do the right thing, what is right for their families. It might be repairing a roof, it might be buying a goat, it might be sending a child to school, it might be getting their wife to have a baby in hospital so that their wife lives and their baby lives. So I think we have these repeated randomized control trials asking the same questions because people are afraid of giving cash. But when you talk about giving corn, people are going to give corn, right? How many RCTs, randomized control trials, are there saying it's a good idea to give food to people living in poverty? But people are giving food to people living in poverty. So I really think it's a paternalistic mindset. And I would say now, as a doctor, for these results, I would say cash should become a prescription for women living in poverty that are pregnant. If we are prescribing childhood vaccines, if we are prescribing malaria chemoprophylaxis, if we are prescribing malaria nets, why can't we prescribe cash to women in poverty when they're going to have a baby? If we see results that show that we can actually reduce infant mortality by 50%, why should we not be doing that?
Miriam, thank you so much for your time.
Thank you, Mark.
Thanks for listening to Global Dispatches. The show is produced by me, Mark Leon Goldberg. It is edited and mixed by Levi Sharp. If you are listening on Apple Podcasts, make sure to follow the show and enable automatic downloads to get new episodes as soon as they're released. On Spotify, tap the bell icon to get a notification when we publish new episodes. And of course, please visit globaldispatches.org to get on our free mailing list, get in touch with me, and access our full archive. Thank you.